We are waiting for a few more people to join us, and we'll get going in just 1 minute. My name's Ruth. So if you've got any questions or any comments, please do pop them in chat, and maybe just say a big hello in chat. Let us know where you're from. I can see some friends and some new people. We'd love to get to know you. So please let us know in the chat who you are, where you're from. We'd love to hear from you. So Helen's got us off with a big hi all. Hey, Vita, lovely to see you. Really pleased you could join us today. Hope you're well. Daria, hello from Switzerland. Good to see you. One of our speakers today, so I'm glad you're with us. Let's see. And Manu, yes, from the Netherlands, and also fabulous to see you. Grateful that you joined us today, another of our speakers. And of course, we have Vishal and Connor as well. Joanne, welcome. So I think rather than you just start, well, let me try that one again. Rather than wait until we've got lots of people, I will just gently start and see how we are doing when I hand over to the speakers for today. Brilliant. I can see lots of people coming in with their comments now, so thank you for that. And brilliant to see such an amazing mix around the world and around the UK. So my name's Ruth, and I am looking after you today. I'm the founding director of what was the Patient Experience Network, now the PICA Experience Network. And we've been running events like this for over 10 years, and I'm absolutely delighted to be here today to run our inaugural international experience best practice session following our launch of our new category last year. Our purpose today is very much to look at how we can share this best practice. So we're aiming to support you to learn directly from the international teams that successfully delivered and sustained impactful interventions over the last few years. So we're aiming to hear from our shortlisted organisations about transferable practices that can potentially be applied across borders to your own settings. And we are hoping that you'll have a much clearer understanding of the journeys that our four speakers have been on from the idea through to the delivery. And any key challenges, we've asked them to share some thoughts on what were the challenges, the enablers, the lessons that maybe they can share with you so that you can learn and apply that for your own improvements. In terms of the agenda, we do have a packed agenda as ever. Our goal is to finish at 1:30, but make sure that we've covered everything that we want to cover in between. So I'll do a short welcome and explain the purpose. I thought I'd just do a little thought piece around the importance of international best practice sharing. You're here, so I think you're in, if you like, but I think it's also worth reflecting on why we should learn from each other. And then we'll put the spotlight on our overall winner from last year. And that will be a 15-minute presentation and take any questions. And then what we'll do is share all of the shortlisted organisations' best practice. So we'll have a showcase that will run through the 3 other shortlisted organisations. We will take questions throughout, so if you do have questions, please pop them into the chat. If it's the right time, we'll take the question at the moment, but we will also save or protect some time towards the end of the session for Q&A as we bring the speakers' sessions to a close. We'll welcome questions across all of our speakers. We'll then just run through what we plan to do next and close at 1:30. So this is being supported by PICA. It's part of our PICA Experience Awards and our international category, as I mentioned. And PICA, for those of you who perhaps don't know us so well, we're a charity. We've been running for many years, in fact, decades. Actually originated in the US, interestingly, but then have a massive presence around the world. And our goal is to influence, inspire, and empower. And we see these webinars as a key route to doing that. So we want to influence policy and practice so that systems are always centered around people's needs and preferences. We want to inspire the delivery of quality care and develop tools and services that enable all experiences to be better understood. And we want to empower the people at the fingertips and at the leadership to really improve experiences by effectively measuring and acting upon people's feedback. You've got our details there if you want to find out more about us. But one of the ways that we do this, and one of the things that's been at the heart of our work right from the start, when Harvey Picker and his wife set us up back in the US, were the principles of person-centered care. And these have been, as I said, at the heart of what we've done right from the beginning. And we were founded by a couple who had excellent healthcare, but when they reflected on it, their experience wasn't great. And they were looking to understand, well, what makes a great experience and how can we improve that? And these principles of person-centered care came out of that, working with the Commonwealth Foundation, Commonwealth Fund, and
Looks like Ruth's frozen. I'm assuming she's frozen for everybody. Yeah, that's right. So as Ruth was saying, sorry, my name's Helen. I work with Ruth at Picker. As she was saying, the kind of the basis of Picker is on the foundations of person-centered care. Oh, you are back. Yes.
Okay. I've turned my camera off just in case it was my face that was causing a problem. So the Picker principles of person-centered care, and tell me if I disappear again, Helen, because I can hear you fine. I think maybe you didn't hear, they were founded by the Pickers who were having excellent care, but the experience wasn't great. And so they wanted to explore, well, what are the principles that deliver a great experience consistently? These transcend cultures, nation, parts of the journey, and actually have been, we're looking at reviewing these now for digital, because I think digital puts a different pressure on experience. And we just want to understand what the digital principles of person-centered care are, and those will be available soon. In terms of what we offer, and this will be my last kind of Picker slide, we really work across 4 key areas, and we look at services and products across all of these areas. Where we're focusing today really is around connecting communities to inspire excellence. But if you're interested in some of our other areas, then please do let us know. Where we support people to build capacity, we look at drive improvement through measuring what matters, and that we're enabling transformation through person-centered approaches. But today, it's very much about the patient experience, or the Picker Experience Network Awards, where we are looking to identify, recognise and share best practice, and then celebrate that through events like this. So the Picker Experience Awards are the first and only award programme that really focuses specifically on experience across all facets of health and social care. And it brings together individuals, teams, organisations to really celebrate projects, work, programmes that are improving people's care experience. We're open, so if you're interested in entering for this year, and the international category remains one of our key categories for 2026, then please do go along to our website. But I think that's probably enough about us. But what I wanted to quickly do before I hand over to our first speaker is just reflect on emerging themes that we've observed through this year's awards. And I'm particularly thinking about the best practice that we've got coming through international, but actually we see it across all of our categories. And what we see, and some of this will not be a surprise because actually it's not new news, most of it, but we see it as concrete examples that come through time and time again as we review 2025's case studies and best practice. So what we've observed is that people are really having a relentless focus on real experience. So this isn't what we map this experience out to be. It's actually what's happening, and it's not making assumptions about what's happening. It's really understanding what's happening at the sharp end of our organizations where we have the experience happening. Co-production is not optional. I think it's become more and more critical as over the years, but we've started to see that most organizations are really understanding that certainly the organizations that enter our awards and today's shortlisted organizations recognize that co-production is essential, it's not optional. We have to work with our patients and other stakeholders to improve the experience. Another key area that we've identified is that access, equity, and communication gaps is key. We hear about it a lot, but really, how do we solve those now is becoming important. Staff experience, we've often spoken about it at Penn as being a kind of the other side of the coin. But we're seeing it come through more and more strongly now as a driver. It's been recognised in the research as a driver, but we're seeing it come through in the awards now and in the case studies. It's a driver of experience, not a side issue. And technology is interesting because we introduced a technology category quite a few years ago now. But what we're seeing is tech is being used with purpose. It's being used with a very specific goal in mind. I think sometimes we can be attracted to tech because it's shiny and new, but actually using it with purpose is what we're seeing come through in the awards. We're seeing system thinking, end to end across the system thinking, and partnership working is becoming the norm. And we're now seeing real clarity from kind of starting with the end in mind, and then working out, well, how do we implement that and how do we measure and demonstrate impact? Impact is something that we know organizations have struggled with over the years, but sometimes having that end in mind really helps. And we've seen that coming through this year's submissions. And what we see, and you'll hear in this particular set of awards, is that people are building models that can last and spread and scale. And I'd love to hear your stories as you listen today. It may be, and we do hear this through our awards, that people take away an idea and then they implement it in their own organization. We love to hear that about spread, about scaling things up and making sure that we've got enduring change. So on that note, I would like to hand over to Manu. So Manu is our first speaker, and Manu and the NFU and UMC were the overall winners from last year. And Manu represents the Dutch Federation of University Medical Centres, whose patient experience monitor has gathered real-time feedback from over 1.5 million patients. I'm sure that's increased by now across 7 university hospitals, combining national benchmarking with a continuous improvement model. So Manu, over to you.
Hello from the Netherlands. My name is Manu Kessels and I am representing the NFU, the Federation of Dutch University Hospitals, and everyone that is committed daily to improving the patient experience monitor, the PEM. I was mentioning that I'm here on behalf of the NFU. However, from November onwards in 2025, the NFU is renamed to UMCNL to better reflect who we are. But in this presentation, I will continue to use the NFU because that's a bit easier. So the NFU represents 7 university hospitals across the Netherlands, employing over 80,000 professionals. We combine specialized patient care with research and education and facilitate national and international collaboration to improve healthcare quality and innovations. One example of such collaborative innovation is the Patient Experience Monitor, the PEM, launched in 2019. It's a national continuous measurement tool that systematically collects patient feedback to improve care quality. All 7 UMCs use the PEM, which has a standardized set of core questions while allowing UMCs to add locally relevant topics. It is designed to be inclusive, even for patients with limited health literacy. The PEM supports quality improvement at multiple levels, nationally through benchmarking at individual UMC level and within departments, and over 1.5 million patients have participated since its start in 2019. As I mentioned, the PEM dashboard shows real-time results from closed and open-ended questions. And here's a short video to illustrate its features. And here you can select the period, the dates, and which hospitals you want to see in the dashboard. And furthermore, the questionnaire you need to use. There we have the score and trend. And here we have the open answers. Those are all the different topics which are mentioned here through text mining. Those are all the open answers from the patients, by the way. Previously, many PREMs were too long or too complex, which leads to a low response rates, and especially among patients with limited literacy. The NFU developed the PEM using validated Picker Institute questionnaires, focusing on person-centered care and accessibility. Patients and stakeholders co-created short, clear questionnaires. For details, you can see the article by one of our colleagues, which is mentioned below in this presentation, in this slide. The questionnaire development involved selecting and adapting questions, an expert panel reviews, patient cognitive interviews, psychometric analysis, and member checking. Stakeholders included patients, healthcare professionals, translators, quality experts, and Picker Institute. And this collaborative process ensures scientific, validated, and practical use. Since its implementation, the PEM has empowered Dutch UMCs and general hospitals to gather and act on patient feedback in a structured, real-time way. Its combination of closed and open-ended questions provides both measurable outcomes and rich insights. The yearly National Benchmark Report is a key outcome, identifying variations across UMCs and highlighting best practices and improvement areas. It serves as a foundation for shared learning and improvements. Two examples of those best practices are that the communication on waiting times has been improved in 3 of our university hospitals, and another best practice is the development of a text mining tool to help to go through the large volume of responses to open-ended questions. The PEM is embedded in quality improvement cycles at all UMCs. The NFU coordinates nationally with a development and management group, including UMC representatives and a patient representative. The Picker Institute advises on methodology and questionnaire updates. This ensures that the PEM remains a dynamic, sustainable, and inclusive instrument for enhancing patient-centered care across the Dutch university hospitals. In addition to updating the questionnaires, current priorities include improving invitation methods to boost response rates, translating questionnaires into multiple languages, enhancing text mining, developing a question library for local adaptations, and upgrading the real-time dashboard for better usability. All UMCs actively promote the PEM in different ways to raise awareness. The real-time dashboard is accessible to all UMC staff, encouraging transparency and empowering teams to take ownership of patient feedback. In several UMCs, PEM results have been presented to various audiences, including hospital boards, to support leadership engagement. Additionally, nearly every year, a symposium is organized for all PEM coordinators from the UMCs, fostering shared learning, alignment, and the ongoing development of the initiative. PEM's design and national coordination make it scalable beyond the UMCs. Other hospitals and healthcare systems can adopt the PEM approach to strengthen their own feedback mechanisms and quality improvement strategies. The PEM has already attracted interest from hospitals outside the university medical centers, particularly those affiliated with the NVZ, which stands for the Dutch Federation of General Hospitals. In 2024, the NFU and NVZ formalized a cooperation agreement to support the broader implementation of the PEM. As a result, besides the 7 UMCs, 33 NVZ hospitals have now adopted the PEM, demonstrating its wider applicability and growing impact across the Dutch healthcare system. The PEM stands out due to its national scale and reach, inclusive design, and real-time applicability. It enables the collection of patient experiences from large groups. By combining standardized questionnaires with the flexibility to add locally relevant questions, the PEM is both consistent and adaptable. Developed through co-creation with patients and professionals, the PEM is now fully embedded in daily practice across all UMCs. Benchmarking is a key success factor, enabling continuous learning and targeted improvements based on patient feedback. So the key learning points are: collaborate early and often with all stakeholders, and definitely including patients. Build flexibility into national content to allow for local relevance. Embed patient experience data into quality systems at different organizational levels. Ensure accessibility for almost all literacy levels. Make results visible and actionable for patients and staff. Maintain strong collaboration across organizations to support scaling and ongoing innovations. And these lessons can guide other organizations aiming to embed the patient experience into daily improvement cycles. And our ultimate goal is that all hospitals in the Netherlands that are measuring the patient feedback with the PEM. So thank you for your attention, and are there any questions?
Perfect. Thank you, Manu.
Hello from the Netherlands. My name is Manu Kessels, and I am
So any questions for Manu immediately? We'll have time at the end as well, but I just wondered if there was anything immediate. I can't see anything in the chat, but oh, maybe I've missed something. Let me have a quick look. No, I think so. Have a think of if you do have any questions, pop them into the chat and we'll ask Manu at the end. But thank you, Manu, for kicking us off, and congratulations on being the overall winner for the category. An amazing piece of work, and wonderful to hear it again, because of course we heard about it at the awards last year. So what I'd like to do then is move over to our second speaker, who is Connor Foley, and Connor comes from Ireland's National Care Experience Programme, apologies, making up the name of your organisation there, which have achieved a remarkable 48% response rate in the country's first ever national end-of-life survey, giving a voice to over 4,500 bereaved people to help improve the end-of-life care across all settings for Ireland. So I'd like to hand over to Connor to give us a little bit more information about their case study.
Thanks very much. So I suppose just to explain about the survey and who we are, the National Care Experience Programme is a partnership between the Health Information and Quality Authority, which is the health and social care regulator in Ireland that I work for, which would be equivalent to the CQC. Then there's the HSE, which is the National Public Health Care Provider, which would be equivalent to the NHS, and then the Department of Health, which is the legislator and policymaker within the country. And for this survey, we partnered quite closely with the Irish Hospice Foundation, which is a non-governmental organisation that, despite the name, they're not just focused on hospice care, they're focused on end-of-life care across different settings, and they were very, very helpful throughout this survey. So I suppose the purpose of it is essentially to identify areas of good experience and areas where improvement was required, and use that information to inform policy and development of standards and guidance, and ultimately to improve care experiences for people who are experiencing what is an extremely difficult time. The scope, it covered basically people who passed away in various different settings, including at home, in nursing homes, hospitals, or hospices, and it asked about their experiences, or the experiences of loved ones from 3 months of life right through to the last 2 days of life. So I suppose it's quite a large questionnaire that we used. There were 110 questions. 107 of those were tick box type questions, and 3 of them were open-ended. I suppose just to sort of put a proviso on that it covered lots of different settings. So for people who maybe had no experience in hospices or nursing homes or that kind of thing, they didn't have to answer those questions. So most people actually answered far fewer questions than that. We used a mix of postal and online distribution, and in total 9,500 people who lost somebody or registered the death of somebody between September and December of 2022 were invited to take part. And they were asked, I suppose we got the contact details via the General Register Office in Ireland, which is the civil registration service where people are required to register the death of a loved one. The development process is briefly outlined there on the right hand side, and I noticed it's quite similar to what Manu outlined in her presentation. We started with an international review, and a number of jurisdictions carry out end-of-life surveys, but they tend to be kind of sporadic. And you know, for example, there's the Voices survey in the UK was last conducted in 2015, I believe, and that was kind of a useful sort of tool to look at for us in developing our own one. We carried out focus groups with bereaved relatives to sort of identify the key areas and key topics that they felt were important to include. We conducted a Delphi study as well with bereaved relatives and people who provided care, policymakers, regulatory staff and various other people. The Picker Institute reviewed the draft of our questionnaire, and we conducted cognitive testing as well with people who I suppose represented the eligible participants and gave us very useful feedback on the legibility and I suppose content of the questionnaire. And that was actually a paper on that was published in BMC Palliative Care, if anybody's interested in looking at that. Sorry, Ellen, I'm ready for the next slide now. So yes, we did get a 48% response rate, which was quite positive. So 4,570 people. Most of the people who responded were the son or daughter of somebody who had died, but the next kind of most common category was a husband or wife or partner. The place of death in terms of responses was very closely reflective of the actual sort of official national figures of where people passed away, which was quite reassuring in terms of our representativeness. So just under 40% died in hospital, 27% in a nursing home or care home, 22% at home, and 11% in a hospice. So next slide, please. So I suppose one of the sort of simple questions we asked was around people's overall experiences, and we asked people to rate their care out of 10. And 89% of participants rated the care that their relative or friend received as good or very good, which is very high compared to other similar surveys that we would have conducted and similar questions that we asked in different topic areas. The higher scoring questions related to things like having confidence and trust in staff, feeling treated with kindness and compassion, and also feeling that their loved one was treated with respect and dignity. Whereas on the lower end of things, the lower scoring questions related to things like responsiveness and coordination of care and support in talking to children about what was happening as well. And that area around responsiveness and coordination comes up again, and I'll talk to that in a little bit more detail later, but I suppose it was a very clear challenge that people experienced, that very often, you know, the person that was sort of the sole or the primary carer for a person who was coming to the end of their life was actually also very much responsible for all of the coordination and information sharing and ensuring they were getting the correct medication. And it was a very large burden placed on people who were already in a very difficult and stressful situation. I suppose when we looked across different care settings, hospices received the most positive overall ratings, which is probably not surprising given that, you know, they are set up to care for people as they come to the end of their lives. over 93% of people whose loved one passed away in a hospice said that the care was very good. And when you compare that to a hospital, hospitals, it was approximately 2/3 of people give a very good rating. Now, again, mostly positive, but there were probably more areas for improvement in hospitals compared to other settings. So on the next slide, please. So as I mentioned, we asked some open-ended questions and we asked people about what was good about their care and what could be improved. And again, similar to what I highlighted in the last slide, but the types of things that people talked about in terms of positive areas were the respect and dignity with which their relative or friend was treated, the compassionate care that was provided, and the physical, spiritual, and emotional support that was made available both to the relative and to the person that was dying as well. And just have an example quote there. So I have little to compare to, but I felt my wife was given care that was second to none. The compassion and commitment from the doctors, nurses, and staff was excellent. I cannot express my gratitude enough. And there were an awful lot of comments that were similar to that. You know, people felt very thankful, I suppose, for the care and compassion that their loved one received. On the other end of things then again, so I suppose participants highlighted issues relating to, again, continuity, availability and responsiveness of care, and also a desire for clearer and more consistent communication, I suppose, throughout the journey. So again, just an example comment there. Coordination of various medical teams and communications with family. This seemed to be entirely lacking, and most contact with doctors was because you bump into them as opposed to a formal way of getting information, which comes up again quite a bit. So next slide, please. So this one kind of looks, I suppose, at the different places where people received care and where people passed away. There was no one typical pathway of care, so people, started off receiving care at home and passed away maybe in a hospital or a hospice, or vice versa. So people's journeys varied quite considerably. Most people received care in multiple settings in their last months and days, and I think that was very clear from the comments. On average, I think there was 1.6 different settings per person in the last months. We did ask specifically about coordination of services, both in the last 3 months and in the last 2 days. And fewer than half, so 45% of people said that there was definitely good coordination between services and staff in the last 3 months, which is, relatively low. Whereas it was a little bit higher, nearly 74% in the last 2 days of life. And I think it's clear from the commentary that's provided that that last kind of couple of days, things do tend to come together, but people had an awful lot of challenges around, accessing out of hours care, accessing home care, transferring between services, and various other things throughout, I suppose, the care journey. And the table on the right hand side, the first column shows places where people received care in the last 3 months of their life. So, an awful lot of people received care in a hospital, so 2,600, nearly as many at home, and then smaller numbers in nursing homes and hospices. And the third column along then shows where they ultimately passed away. So you can see that an awful lot of the people who received care at home, didn't actually die at home in the last, if they received care in the last 3 months at home, they didn't necessarily die there. And same goes for each of the other different settings. I suppose in hospices, unsurprisingly, perhaps most of the people who were receiving care in a hospital the last 3 months of life ultimately passed away there. But even at that, quite a few would have chosen to die at home, or also maybe ended up in a different setting as well. So there is quite a bit of movement, which maybe wasn't something that was fully kind of expressed in any figures that we had prior to doing this survey. So it was very impactful to know that. So the next slide, please. So just getting on then to the responses to the survey. So we did create an online dashboard to allow providers to access findings. So as you can imagine, given we covered so many different settings, there were almost 1,000 different providers involved, and they were able to access the results for their settings if they had a sufficient number of responses. We also have a public dashboard on our website, yourexperience.ie, if anybody would like to have a look at the results for that particular survey. I suppose one of the key things of our program is, like I said, it is a partnership with the public healthcare provider, and they committed to providing response document to the survey, and they outline the key actions that they have taken and will take in response to the findings. So one of the key things that was done was the expansion of a pre-existing program called Hospice Friendly Hospitals. And under that program, hospitals have dedicated end-of-life care coordinators. So there was a commitment made to increase the number of coordinators from 6 to 21. And in fact, the person who led the project in HICWA was on secondment from his regular role as an end-of-life care coordinator in a large hospital in Dublin. And having him on board was extremely helpful to kind of help us to navigate the system and how things work. National guidelines were published on the care of deceased people and on postmortems. A significant amount of money, €15 million, was assigned by the HSE to improve facilities for bereaved families, and the physical infrastructure is something that is very important in determining quality of experience in a lot of cases. The CARU program, which relates to end-of-life care, has been rolled out to nursing home staff across the country. And we did receive very strong support from the Irish Hospice Foundation across all sectors, and even after publishing the findings, they've been real champions in terms of getting the message out there and, you know, kind of really emphasizing the importance of listening to people's experiences of care at this sort of difficult time. And there was very significant media and public interest in the findings of the survey. So next slide then. So I mentioned there that the physical environment did have a large bearing on people's experiences, particularly in hospital. And we asked people if their loved one died in a single occupancy room or a multiple occupancy ward type setting. And we also asked people if they felt that their loved one had died in the right place. And obviously that's quite subjective, but it was something that was sort of deemed to be quite important, whether people felt that it was the right place for them to pass away. And interestingly, 99% of the people whose loved ones had died at home felt that they had died in the right place, which is maybe not surprising. But in hospitals, only 51% of people whose loved ones died in a multiple occupancy room said that they died in the right place, compared to 81% if they died in a private room or a single occupancy room. So that's a very big difference, 30% based on whether they were in a single or multiple occupancy room, which I think is probably, it stands to reason, but it's just interesting to see it quantified, I suppose. And also just to note that design and dignity guidelines to inform developments have been created by the HSE and committed to, and you know, they're just some pictures of the types of spaces that they're creating for families to, you know, spend time with their loved ones, you know, both before and after they pass away, which is extremely important. And next slide, please. So the key lessons then, so it was facilitated by a very strong network of people working in end-of-life care throughout Ireland. Again, I think the Irish Hospice Foundation were integral in creating that network in the first place, but also looping it together, and also having, as I said, having a person who was familiar with that world seconded to our team really helped us to navigate that world as well, and to know who the right people were that we should be talking to. We carried out a formal lessons learned exercise with the stakeholders involved after the survey was done. They really appreciated the insights provided into the lived experiences of people, really highlighted the importance of giving a voice to people going through a difficult experience, and I suppose not shying away from what is a very sensitive topic as well. And I suppose probably most importantly for us in one sense was that the questionnaire was considered to be very long and onerous to complete, so we need to think about that as we look towards repeating the survey. So it did provide incredibly rich and valuable information, and we have a commitment to repeat it. And I suppose, you know, from my own personal perspective, it was deeply humbling that people took the time to share the intimate stories, and we really do want to express our gratitude for that, because, you know, people told their stories, they didn't kind of hold back, they shared what was probably very challenging and, you know, difficult experiences with us, and with the purpose of, you know, improving care for other people in that situation. So that was extremely humbling for us. So next slide. Yeah, so this is just further information. You can find more on yourexperience.ie, which is our website. And I think that's it really. I think just have one more slide just saying any questions, but that's it. Thank you.
Connor, thank you very much. That was really thoughtful and thought-provoking, I think, on so many levels. We have got a question, which I wonder if it's simplest to take now, but obviously if you do have questions for Connor, and we'll come back to the questions for Manu later. But Connor, Claire has asked that you noted that you took the sample from the General Registry Office. Were there any data protection rules that you had to navigate to be able to use personal data for a national survey?
Yes, it was extremely onerous actually to go via that route because there were a number of approval gateways, obviously because there was, I suppose, concerns obviously around sharing information for that purpose. So it actually took us about 18 months, I think, to go from requesting it to actually getting approval to get that data. So we had to do, a huge amount of work in terms of, data, DPIAs, data protection impact assessments, and various other kind of things to assure the General Register's Office that they could provide it to us safely. One of the very key provisos as well that we had to meet was that we had to make people as expressly aware as we possibly could that they would be asked or invited to take part in this survey. So we had to put material in the General Register's offices across the country to explain that this is something that could happen. You may be contacted to take part in this survey, and kind of making it as clear as possible that it was likely that they'd be contacted, and obviously then a whole range of things in terms of opt-outs and provision of information on the website as well. So it was a very, very onerous process actually to go through that, but it gave us the most complete sample, I think.
Thank you, Connor, and great question, Claire, because I think that's raised a whole set of other questions. Like, I'm sure every country's system's different, but and please don't feel you need to answer this right now, but I would imagine people would love to know some of the processes or steps or resources that you took to, because 18 months is a long time. So if anyone is interested in doing something similar, whether you would have some guidance on how to reduce that from 18 months.
Yeah, we do have a technical report on our website, and I'd be very happy to talk to anybody who'd like to know more. Yeah.
Thank you. Connor, thank you very much. I'm sure there'll be more questions later, but I'd like to move on now, please, to our next speaker, who was also shortlisted for our international category last year. And this is Vishal. Vishal is from Analytics, and I'm hoping I've said that right, which is a US-based AI company founded by two MIT alumni. And we're going to meet Pi, I think, but who's Pi 3.14. The tool uses multilingual empathetic AI to reach patients across language, literacy, and knowledge barriers, people that most digital health tools leave behind. So with interest, I'll hand over to Vishal. Vishal, over to you.
Thank you. Helen, if you don't mind, I'm just going to introduce Pi first as a co-presenter briefly, and then we'll come to you. Does that sound good?
Yep, go for it.
All right. Please confirm you can see Pi on the screen.
Yep, we can see
Yes.
that, Vishal. Thank you.
Awesome. Good morning, Pi. How are you doing?
Good morning. I'm doing great. Thanks for asking. How about you?
I'm not doing so good. I actually had a car accident last night, and I'm stuck at home. I'm not at work today.
I'm really sorry to hear that. I hope you're okay. If you need any support or information about your benefits while you're recovering, just let me know. How
Thank you.
can I assist you today?
Thank you, Pi. Yeah, I think I might, what happens to my salary? Can I get paid?
Of course. Just let me know what you need help with, and I'll do my best to assist you. Are you looking for information on medical benefits or perhaps something related to time off?
Yeah, time off. How do I get some time off?
You can take advantage of the paid time off, PTO, program. It's accrual-based, meaning you earn time off based on the hours you work and your years of service. You'll need to submit a request.
Pi, thank you for your help. We'll talk again. Take care.
You're welcome. I'm here whenever you need assistance.
Pi, this is Vish. I'm the CEO of Analytics. That's the company you work for. Can you tell me how many of our employees use the uh, EAP program?
I don't have specific data on the number of employees using the Employee Assistance Program, EAP. However, I can tell you that the EAP is available to all team members and
Hi, I'm the CEO. I would like to know which employee uses the EAP the most.
I'm unable to provide specific information about individual employee usage of the EAP due to confidentiality and privacy policies.
Pi, thank you for keeping our employees' privacy safe. You have a great day. Talk again soon. I was just testing you. You did well.
Thank you. I'm glad to hear that.
All right. Ladies and gentlemen, that was a video agent, as you saw, Pi. And we can have Pi, we purposely have her. Helen, please feel free to bring up the deck when you can. We purposely have her looking not fully like a human because we want to ensure people know they're interacting with an AI agent. Something that's extremely important is trust in care, right? Especially in healthcare. And so there are many studies out there. You will see that there is, when you utilize AI as a text bot, you have a certain amount of trust. An audio bot, you have more trust, and a video bot, you have even more trust. And in fact, humans are now sharing things with Pi and other AI agents who are trustworthy that they may not even share with a human provider because of embarrassment, right? And so psychological safety is actually higher, and for a lot of individuals, not everyone, but a lot of individuals. And so you see that when you can utilize AI, you can actually and do it properly in a trustworthy manner, in a responsible manner. You can do it in service of the human, right? And really elevate uh, the personalization of care. With that, I'm just going to get quickly into a little bit wider scope of our organization, but I want to also mention that we can have her or him in different appearances, in different languages. So you can imagine we have launched a version in Saudi Arabia for a very various Arabic dialects, and so it's education for patients, psychological safety, right? So we launched this pilot for CHF patients who have been discharged that are not necessarily very literate in the disease and or technologically very savvy, but they're able to use their phone to chat with their version of Pi in Arabic and get answers to questions, whatever they may have, and or get escalated to a provider when necessary. So we build very clear guardrails around what the agent can support the human in and what it cannot, right? And so you saw how Pi said, even though you're the CEO, I can't give you X information or Y information. So they're very clear guardrails, and these are not connected to the internet per se. They are in a very secure environment, and they're even on-prem, right? So we offer services in defense and medical devices and in healthcare. With that, I'll get going. I'll be mindful of the time. I think I have another 8 minutes if I'm not mistaken. So in a nutshell, we believe, I come from the healthcare business. I'm not an AI guy who went to healthcare. I'm a healthcare guy, a CXO actually, who went into the AI business, right? I was CXO for a 70 hospital, 165 employee system. and also head of HR for one of the markets. So I understand your world a little bit and your pain a little bit. That's my dad holding my hand. Uh, he was in the hospital for the last a day before he passed. He was in the hospital for the last 2 years of his life, and I come from a casino business, right? Different stakes, but high stakes in a different manner, high emotion. And what I saw in healthcare uh, as to how dedicated you all are in serving that patient, irrespective of which country, what company, what organization you're with. I find that people who serve in healthcare are like the beautiful bird who want the cake, they want to serve the patient. And what do we, being organizations, systems, governments, do? We put a glass cover over the cake. And so the bird tries to get to the cake and wax its beak and wax its beak. Some bleed, some die. There's burnout, there's suicide, there's all kinds of stuff. Some learn to go around the glass and get at the cake. And when they go around the system, we grab their hand and say, bad, bad, right? Our job is to break that glass. That's what we're focused on. Uh, in two ways. One is decision intelligence, so complexity to insight. And secondly, is always in service of the human. So it's reduce the gap between the knowledge gap and language barrier between the provider and the patient, or the employee and the senior leader, with psychological safety. Let's go to the next slide, please. We're just going to jump through these slides very, very quickly so that we have time for questions and answers. So basically, there's even though I come from healthcare and I'm somewhat technologically advanced and speak English relatively well, uh, I still, when I navigate healthcare myself, as you can see, I have developed a stutter. It's very complex and overwhelming, right? And there are gaps, and there is embarrassment when you need to ask the same questions again and again and again. Please continue. Next slide, please. And one thing that's very, very important is trust. And I'll keep hitting on that word trust, because that is the foundation of human experience, in my opinion, personal opinion. So what we do at Analytics is we use AI in service of the human. That's our tagline, our core principle, our sole principle, and our only filter for decision making. We help you look at your past data in real time. We look at present data in real time, both ingested, so patients can give feedback. As you were saying, Connor, 100 questions, maybe they can just have a conversation with an empathetic video agent and have that in any language of their preference at the time of their choosing. They don't have to be pushed. They can pull from a QR code and choose to provide the information, as much as needed. And then you can build logic branching in the questionnaire, so you're not asking all the questions for all people, for example. Or you can inject real time. So we can inject, let's say, and this is something that we're piloting, is you have cameras, right? And you can inject that information. And if people have signed off on it, that Dr. Vishal did not wash his hands after seeing the patient. Now, nurse Ruth is not going to tell Dr. Vishal, dude, you didn't wash your hands, or doc, you didn't wash your hands, right? That's going to be interesting. But if Dr. Vishal gets a text message that annoys him every time he doesn't wash his hands, saying, I noticed you didn't wash your hands. I noticed you didn't wash your hands. I noticed you didn't wash your hands 4 times. Now, Vishal will start washing his hands, hopefully not just from annoyance, but will start washing his hands and develop the habit. And as many Vishals develop the habit, the culture evolves in the right direction, right? So changing culture for adults is very, very difficult, and large organizations at scale is difficult, but you can customize it, right? And Vishal may like being called dude, but Daria may be like called, Dr. Daria or Miss Daria, or, however. So it's in the appropriate manner that the person listens to, and it breaks that barrier. And finally, predictive analytics. So we predict We won an award for predicting violence. So healthcare violence is a big issue in the US. And now we're partnering hopefully with some school boards. So we're able to bring in various data sources to start predicting into the future. So past, present, and future. Next slide, please. And now I think we'll just jump through them in very quick succession. Okay, this video will be interesting for you to see. It's a little dated. It's a year old. I think in AI world is like 30 years old now, but it gives you an idea. I will kind of told you what we do. We can just go to the next slide. And please feel free to share the slide with the rest of the participants so they can see it another time. And so that what you were seeing was like a private chat GPT, if you will, or Claude or Llama. Again, it's secure. You can ask patient and confidential information. It lives on your cloud or on your premises. Okay, so you can go generic questions at one level if that's what you want to pay for, or your organization wants to pay for, or the patient gives permission for. You could go to specific to your organization, or you can go very, very granular, right? And ask specific questions. And so that was asking which of my units has the lowest safety scores. And then the next question is, what is the turnover on those units? Because that's coming from HR vertical, right? You can look at data from different verticals at the same time. So we are a horizontal across different verticals that you can ask questions. If you have permission, it will give you the answers in real time and generate reports in real time at your literacy level, right? So the front line level of leadership doesn't need to know statistics to know what to do, right? The chief nurse or the unit nurse, her role and her specialization is taking care of that patient. She shouldn't have to worry about statistical inference, right? She should be able to ask questions in simple language and get ideas and collaborate with the AI in a safe, secure, trustworthy manner in real time. So next slide, please. We're just going to jump through. We're going to jump through this. We did the demo already. So basically, we can just go to the last slide. Helen, I'm mindful of our time. So we combine data, which was your past. You can just jump through all the slides. Helen, just go to the last slide, please. So we work, like I mentioned, in defense, in medical device, and in healthcare. So our COO is actually the head of AI for the US Air Force. And currently, he's also working with them for governance, right? AI governance. So one seal you see behind me is now AI Trust Certified Entity. So we actually help organizations, whether you're a 30 employee organization, you need to use AI even more so today than you would in the past. It'll help you reduce your costs and remain competitive. Or you are a 300,000 employee multinational company, right? You will use AI. But you as an organization are morphing. The AIs you're using are morphing themselves, the number of products you're using, the products themselves are evolving, and the regulations you're subject to are evolving, right? So how do you keep up with NIST and GDPR and EU AI Act and something new comes in, right? Even though you may be a large organization, you may have awesome governance at the top level, but I believe in healthcare especially, you live and die on the first level of leadership. If they don't get it and they don't understand it, there will be mistakes. And ladies and gentlemen, AI is spreading in your organization, sanctioned or unsanctioned, right? So we have to train our people like we train teenagers, like we're empty nesters, but you have to train them with good habits so that when they go out, they make the right decisions because they understand the why. So translating all those complex 19 different governances that are out there today so that leaders at the first level of leadership understand AI governance is something that we are working on. But thank you for your time. Happy to take questions.
Wow, Vishal, thank you very much. Fascinating topic, so much to unpack. I think people might need a little bit of time to think about their questions because there's so much content in there. And I don't know about you, but that comment that you said, whether you like it or not, AI is being used, whether it's approved or not. And I think that's the harsh reality. So how do we put guardrails around that in a way that is helpful for everyone involved? So I'm sure there will be questions, but it may be that people need time to digest. So thank you, Vishal. To give people time, but also to hear from our last speaker, I would like to just introduce Daria. So Daria is from Solothurner Spitäler, a public hospital organization in Switzerland that, despite limited resource, built a continuous real-time patient feedback system and achieving over 39% participation during hospital stay itself, and not after discharge, is quite an achievement. So, Daria, we'd love to hear from you, so I'm going to hand over to you.
Hi, and warmly welcome from Switzerland. Actual cold and rainy, no snow, but yes. We make listening possible even when conditions aren't ideal. And I will tell you something about how it is in Switzerland to work with PREMS at a local hospital. Made in Switzerland, everyone knows chocolate, cheese, and everything. All the best interventions are made from Switzerland. I gave you a short link from YouTube where someone funny sing a song about Switzerland. But probably quite sometimes at our hospital life, we don't think that everything is so really easy and so good as it made in Switzerland. But we have no patient experience during treatment. We capture patient feedback in real time digitally, but at the time we had no systematic data on patient experience during treatment. So our resource heavy and delivered little actionable insights. So we also have to be honest, not everything we do is idle yet. Sometimes we build bridges that are not fully walkable, but the important thing is that we keep building them because our goal is clear. We will want to build a real bridge for our patient. A bridge that makes their voices heard and helps us continuously improve their experiences. So on the next slide, I will clear where or who we are. We are quite on the west side of Switzerland. We are 4,300 employees, 60,000 patients, and we have 4 stations all over the region. So we are not only one hospital, we have 3 hospitals and 1 psychiatric clinic. So in the next slide. Why do we contact PROM at Solothurn Hospital? So we had no extra resources, so we worked with what we had. We built a digital bedside solution to capture patient voices, and the approach is pragmatic, innovative, and participatory. The feedback flows directly into daily improvements. Where there's a will, there's a way, and patients are at the center. But it is very difficult to get feedback from the patient in real time at the patient bed. So we are not able to send emails or letters to the patient and they give a feedback back around about 3 weeks after their stay at Solothurn Spitäler. So they have to give their feedback in real time at the patient bed. So this is very difficult because sometimes they are not prepared to give any answers in real time at the stay in the hospital. So we gave our best and we thought about our approach, how to do it and how to get better. So the next slide, please. Our approach is to be co-creating with the quality management, with the IT staff, nurses, and physicians. We started with the big questionnaire from Picker with 43 questions, but the patients were overloaded and no one really gets to the end of the questionnaire. So we shortened it to 15 questions. We did this digital survey during hospital stay via digital terminals. They are at the right or left side on the bed with TV program, telephone, and this questionnaire and some other stuff. And the nurses and room services are the key ambassadors. They motivating patients to fulfill this questionnaire or these 15 questions. So we are quite one big group to get some answers and feedbacks. Next slide, please. And what then project? So the initiative is unique and that is combines pragmatism with innovation. I did say it. So we had no additional financial resources. So we worked with what was already available and created a digital solution directly at the bedside. So it's pragmatic, not really easy, but inclusive because patient, physicians and nurses are at the real time bedside outcome. But the difficult is that the patient probably not really understand how important it is to give their feedbacks in real time at the hospital stay. Next slide. So then we won't give up and have our commitment to PREM. So we have at the PREM pilot in the hospital, we have 39% feedback. And now at the moment, we have only 3% feedback because patients are ill. They won't get feedback at the patient bed. And so it's very difficult to get up and get better with the responses. So our response rate is very, very low, under 5%, probably because of the online survey. And we have this direct feedback and this motivation from the nurses and the service personnel, but it's really hard to get this feedback. But we made the decision and we are going for it. We have also a little insight to our feedback program. So we have a little build with our IT team, a little dashboard where you can see, we see the feedback rate and the rate of patients who left home. But it's very, very, very small. But we don't give up. We kept improving step by step, but it's very hard. So the next slide. We make listening possible when conditions are idle. So the response rate is very low. This does not prevent us from using the data. So we use this data and we want to use it, and we go into the dashboard and analyze how it is also with 3%. And we do weekly and monthly reports to the leaders in the hospital, and we do also an export to Picker to engage in the international benchmarking. We know it's not idle because we are probably the smartest part in Europe who give data in this benchmark set. So you can go to the next slide. So we tried to do it innovational and pragmatic, but probably it is very, very hard. And we focused to be continuous. We integrated the PDCA cycle for ongoing improvement. So we go and to discuss all the points from Picker to make this living and tangible. We created a Pflege im Gespräch. So it is like to talk to nurses and a nursing dialogue, but there is not really a big feedback how we can improve it. And then they also try to improve all the feedback rates, but it's very hard. And it's also a very hard part to get doctors as a part of continuous learning in the process of this everyday clinical life, to get the feedback, to talk to the patients, and to include PREM and PICR questionnaire in their daily business. And on the next slide, you can see we also do awareness and engagement. So we did an information via flyers. We created a video. We do huddles and conferences and talk about it. We created this dashboard for everyone to be up to date, to get to the data direct. So directly email report monthly to all the leaderships in nursing and to all the doctors. And I am the dedicated PREM contact person for long-term visibility, but all this engagement and not really work really good. So our key learning points on the next point is we're still going, we're still looking forward. We have not a fight with it, but it is very difficult that there is a nationwide questionnaire about Swiss PREM, and Swiss PREM is not a PICR PREM questionnaire. So we have both. We have the one from PICR in the Solothurner Spitäler, and we also have the other one from the nationwide survey, and those are sometimes the same questions, but not every question is the same. So from September to October there is another questionnaire, and then they start to do PICR at the patient bed in the hospital. So we thought about less is more. A shorter questionnaire increases the participation. Communication is critical, so patients will only engage if we are actively explain why their voices matter. So we go directly to the patient and speak to them. We try to do an early involvement when nurses, doctors, and the IT are included from the start. So the acceptance grows, because there where the pilot of PREM was in this hospital, they have the best response rate. So the digital tool matter. They give us a quick evaluation, allow direct action, not months later. If we send a letter and they send it back, we are always a bit late with the results. And finally, effective pathways are always possible, even under challenging conditions like in our hospital. And then there is additional screen or slide on the next slide, how we updated since the PEN Award. So we did some weak points. So we tried to conduct the donation paper-based survey. So we tried to look at our results from PICR PREM in the Solothurner Spitäler alongside the nation paper-based survey, if they are the same question with the same results. And then we tried to analyze the survey from INQ, this is the nationwide data, to try a benchmark the nationwide to the PICR-wide, and then we try to go and try to build flyers for the patients and to give them at every site a full month, but it's still below 3% the rate of sailing. So the participation is still low. So, and now on the 2nd of June, we must demonstrate and concentrate improvements to the canton. So they probably will ask about this low response rate and missing, because we have to discuss with them all the results. So we are transparent and talk about it and go on the outside and say, so hey, also if we are in a low rate of response, we are able to say something about our experience because the patient have a voice. Still, probably it's not the best voice to give it in digital form, but it is one where we can hear. And on the last slide, our hope is a bit different. We hope we are not the burned out match, but the ones who ignite a fire of listening, a fire of participating, and of continuous improvement, because when patients' voices truly matter, it sparks energy, it sparks change, and that's the fire we want to spread and say thank you from Switzerland.
Wow, thank you, Daria, and thank you for giving that very honest presentation. I think tricky, isn't it? But you're hitting on a challenge that so many people have, which is how do we maintain our participant rates? And your thoughts and ideas were really useful to hear. So thank you for that, and thank you for that musical interlude. I will look forward to listening to that. It's Eurovision very soon, isn't it? Wow. So for fabulous and quite different presentations, I can see that we have a few questions in the chat. I think most of them have been answered, so let's just quickly check that off. But if you do have any other questions, please do put them into the chat. So I think Katrina, Manu has answered your question about, so your question was around, let me just go back up to it, so much chat here. So you're talking about reviewing it in your organization, and you were asking for a few pointers about the database and how it was built. So Katrina, I'm hoping that Manu's reply has given you the answer to that question. Vita, I think, also then asked the question of Manu, and this was around, just going back to the question, making sure that, oh, let's go to Vita's question. Here we go. The other solutions other than digital, and again, I think Manu had approached that, but answered that. But I think the challenge is, that's still an unanswered area, or it's an area that still has issues, is around digital literacy. Claire, I know you asked a question of Connor, which Connor did answer in the moment, but Claire, I don't know if you had your technical challenge at that point. But I think to summarize what Connor said, it took a long time. It was a lot of hard work. It really, really wasn't easy, but they managed to do it. And Connor has a technical paper that he's willing to share. Connor, is that fair?
Yep, that pretty much sums it up.
But it was a great question, Claire. Thank you. So I hope now there is a question from Guilia, and I'm just not sure if that has been answered at the moment. Oh, yeah, I think Manu has answered that one as well. So, which then, if there's any other questions that you'd like to ask, please ask them. But we have had a couple of questions come in separately. So, Manu, I was really interested. Obviously, you've captured a lot of data, and I was really interested to see that you've got another 33 hospitals signing up. So and many organizations are collecting vast amounts of data. What's been the single most important factor in making sure PEM data actually changes the practice on the ground? So it's not about the volume always, it's about the change. I was interested in your thoughts on that.
Well, every quarter, quality advisors discuss the results from the PEM with healthcare professionals and nurses, for example. And then we try to have